But it's this kind of alluring path that keeps you always chasing the fantasy of that next degree of affirmation, that next degree of passing. And meanwhile, many of these kids, they're remaining very unwell. They're stuck in behavioral patterns that are not conducive to good mental or physical health, for that matter. I mean, they're not oftentimes taking care of their own basic hygiene. They're not moving forward with their lives, right? And there's kind of this mentality that, well, I can't live my life. I can't take these positive steps because I'm depressed because of my dysphoria, right? So I have to put the dysphoria first. That's what's going to fix everything, which is a really dangerous assumption because you're spending these crucial years of your life not working on your health, your academic performance. Although, as you pointed out, many of these kids are very bright, and and instead just kind of chasing this fantasy that when you get that next level of affirmation or of passing, then you'll be happy, right? But that's such a shaky assumption to rest your moves on, because then you've potentially spent years investing in this sense of who you are and where you're going and what's going to make you happy, and then you finally get there and you've made these permanent life altering decisions, only to find out maybe that was never it to begin with. And society isn't helping, right, by reinforcing these myths of telling these kids that this is really who they are and that they're going to kill themselves if they don't get what they want. It's so destructive.
Well, that's the issue with social transition is, the AAP did that article recently that said like 94% of kids who transition socially before they reach 12 will persist. Well, of course they will. If everyone in their life is telling them that they're really something that they're not, that makes sense to me. And so how are those kids supposed to go out into the world and just let go of that? Like they're being primed to medically transition. If they haven't already been put on blockers, they're being primed to go onto hormones and surgical, to perpetuate this identity that they've basically lived for half their life. And so it's a very dangerous, not a neutral act, as we know. And I think that that's been the main concern. A lot of parents call and describe having their kids socially transitioned at school. And what are your options? And so we're trying to give people, an understanding that if it is in fact, according to the ACLU, a profound psychosocial intervention, this is CAS review, and then the ACLU calls it part of a larger medical protocol, then aren't those teachers and counselors and other people's parents giving your child medical treatment without a license? Like, I know the penalties for that aren't particularly high, but there is an argument to be made that it's not their place. And so I think we need to start empowering parents and giving them that information so that they know, this is not acceptable and there's a reason why, and here's the evidence that proves that.
I would agree with you
Yeah.
on that, Gigi. So I want to come back to something you said earlier at the beginning when we were doing introductions. You talked about the laws in California, and I'm glad to have you speak on this because I'm in Oregon. I'm not really familiar with what's going on in California, although I know all the blue states on the West Coast and many other places have these very misleading laws that are confusing the general public as to the nature of things like so-called conversion therapy. Something I notice about a lot of these laws is that they don't actually mention the clinical diagnosis of gender dysphoria, right? They talk about people's gender identity and how you can't discriminate on the basis of gender identity, but they never specify what treatment options does this leave available for gender dysphoria. Because if gender dysphoria is it's in the DSM, and in order to be a psychiatric diagnosis, there has to be that component of clinically significant distress or functional impairment. This person is suffering, right? You don't give treatment, and we might disagree about what treatment entails, but you don't give any type of treatment to someone who doesn't have something that they're suffering from. That's how the medical system works. So there is this diagnosis that indicates that the person is having distress. They're having real problems in their life that are making it difficult to function. So if a person is experiencing distress, and I'm so glad, by the way, that you mentioned the high comorbidity rate with obsessive compulsive disorder, because I think we need to talk about that more, because there are such similar brain patterns and behavioral patterns between the way gender dysphoria is currently manifesting in a lot of these youth and obsessive compulsive disorder. So here you have this pattern of distress that you're mentally attributing to the sex of your body. And then there are, cycles of behavior, sort of obsessions, compulsions, avoidance behaviors, ruminations, all pertaining to your sex or gender identity, as they call it. Then you need help with that, right? So then you have gender dysphoria. You go to a therapist, and what are your treatment options? So what people on our side would argue is that you should be able to talk to a mental health professional about how you're suffering and get help for that suffering in the same way you get help for any other kind of psychological suffering, which is comprehensive, careful, evaluating the root causes, the correlations, what all this is tied to, how this came to be, and then what's going to help you out of that most non-invasively, right? The least use of medical resources, the least amount of side effects or, permanent results. And so this is why I'm so outspoken on this issue, because this is really just a departure from how we treat any other psychological problem. So with these laws, you said that there are some misunderstandings that people have about what the law actually says in California with regard to treatment options for gender dysphoria. Although what I'm hearing is that it doesn't actually say gender dysphoria in the law. It says something about a person's gender identity and that a therapist can't say that they will change it. Can you explain that?
Well, according to the Therapeutic Fraud Prevention Act, if you read it, it says no licensed therapist in the state of California can advertise or say that they will charge money in exchange for changing someone's gender identity or sexuality. So that doesn't preclude someone coming in and discussing it. They just can't actively say, no, if you give me enough money, I'll, they can't promise that they can change it. And I don't think any therapist would. The whole outcome for the patient is not contingent upon what the therapist wants. It's what's best for the patient. And I think we can agree that even with acute clinical distress with gender dysphoria, for which, by the way, there's no scale, as you probably know, so there's no way to know what's a 10 and what's a 1. I think the distress needs to be individualized for each person, and it's not. Now it's just you have it or you don't. And I think we need to look at management. There's plenty of people who describe symptoms of gender dysphoria that they lived with before this was a thing, and they worked at it. They grew out of it. And so I think that's really the key is giving kids time and the tools to manage those feelings without giving them a pill or a surgical option. I don't think that should be on the table until they're 25. And I know that's not popular because 18 is supposedly a consenting adult, but you know, those of us with 18-year-olds can tell you that they're still children for quite a while.
They're baby adults.
Yes, and they
Yeah.
still can't conceive of the outcomes for themselves. And I know Abigail Schreier came to our support group early on, right after her book came out, and told us that she said 25. 25 is the number for people. They change their mind on a dime after going all the way. She said she's met people that have gone all the way. They get a boyfriend, they change their mind, something clicks. And so let's just give them that time to explore this.
Yeah, well, I mean, the brain doesn't finish developing until 25. Yeah, especially regions of the brain that are highly relevant here, like impulse control, emotion regulation, ability to plan and see into the future, right? Um, uh, yeah, I mean, we have this conversation all day. We're having it all over the internet, right? About how kids this age aren't capable of making, good long-term decisions. So, but that's interesting the way you clarify the law in California. I really appreciate that. I'm sure that our listeners in California will appreciate hearing that too, because that's very specific to say that they cannot advertise or say that they'll charge money in exchange for changing someone's gender or sexuality. That's now that's very different from someone saying that they offer treatment for gender dysphoria, right? Gender dysphoria means you're having distress about a perceived mismatch between your so-called gender identity and the sex of your body. So if you're having distress about that, we would all argue that let's leave the sex of your body alone. That maybe that's not the problem. Maybe the problem is the psychological distress. And there are any number of reasons that the psychological distress could have become fixated on this particular narrative, this particular issue, just in a very similar way to how with obsessive compulsive disorder, typically starts off with a person who's got higher than average levels of neuroticism, which means a tendency towards depression, anxiety, rumination, right? So it's one of five of the big personality traits that you might hear Jordan Peterson or other clinical psychologists talking about the big five personality traits, right? So we all have our sort of baseline set point vulnerability to neuroticism. Now, there are things that can shift that, like having a meditation or mindfulness practice, exercise, and other positive activities can lower your overall neuroticism. But compulsive disorder typically starts with someone with higher than average degrees of neuroticism and a lot of anxiety. And then that anxiety gets projected onto particular things, right? So it depends on the nature of the OCD, but one common form, I know it's stereotypical, so I kind of hate to reinforce that because OCD can take many forms, but one form everybody knows about is the germ obsession, right? So let's say that is the obsession. Well, for someone with that behavioral pattern, it could be that what's really stressing them out could be any number of things. It could be going on in their body chemistry. It could be stress in their relationships, something going on with work, something having to do with self-esteem. And there's any number of things that could contribute to the anxiety. But rather than thinking about what are my real problems and what do I need to do about them, there becomes this behavioral pattern where the anxiety gets projected onto germs, right? So then the behavioral coping response gets projected onto germs. So then it's the hand washing or the hygiene rituals. So it ends up looking a lot like addiction, where with addiction, and we could talk about addiction to alcohol or drugs, but we could also talk about it too, with food or technology or other compulsive patterns where I notice when I talk to someone who has let's say an addictive relationship with food, someone who has, let's say, binge eating disorder and really struggles with their weight, their mindset around food is, if I'm happy, I want to celebrate by eating food. If I'm sad, I want to comfort myself by eating food. If I'm mad, I want to distract myself by eating food, right? It's like no matter what the emotion is, no matter what the trigger situation is, all roads lead to Rome. It all flows in the direction of food. And the same thing's going to be the way that someone relates to alcohol or whatever their addiction is, because you've trained your brain thousands of times over and over that if I have an emotion, uh-oh, that's scary, that's overwhelming, go to my coping mechanism. So I really think that the way a lot of young people are thinking about the trans stuff, as I hear it from their parents day in, day out, because I talk to parents of trans identified youth almost every single day, it really seems like it's kind of following that same pattern that you see with OCD or addiction, where there's an underlying distress and then there's the interpretation of it, right? It must be about my gender identity. It must be about this. And now the thing I have to do to fix it is I have to pursue this affirmation or this next step in my transition process. And that's what's going to alleviate my distress. And what's really tricky there is how far down the line you have to go before you find out that maybe that wasn't the source of your problems, maybe that wasn't the solution.
Well, and 70% of the detransitioners in the Netherlands paper, 70% said that they realized that their gender dysphoria was related to something else. Now, that's a huge number. So that's exactly what you just described, is people thinking that was it. And then upon reflection, realizing that wasn't what was causing it. It was any number of other comorbidities. And what we've noticed, and I'm sure Josie can attest to this, is the number of kids coming in. There's columns. They have autism spectrum disorder. They have sexual trauma. They have same-sex attraction that they're grappling with. And I guess it's very common in gay and lesbian communities for kids in high school and maybe earlier to put on the persona of the opposite sex, to sort of try it on. But it was never meant to be permanent. It's identity play, which is totally normal. It's just they've medicalized and pathologized something that's totally normal, and now it's a different track. And it's a perfect little basket to put all of your woes in, because you don't have to work on any of the underlying conditions. You're trans, and they'll fix it with surgery and hormones. Easy peasy. That's the frustrating part, is it absolves everybody from guilt too. David Bell talked about this, the clinician from Tavistock, is that parents buy into it because they don't have to look at what they might have done in the past to lead their kid to this point. They can just go, oh yeah, they're trans. Okay, well, let's fix it. It just absolves everybody from any investment in the actual underlying conditions.